Hello and welcome to our last video of our Chapter 21 video series where we're going to discuss Section 4 on secondary lymphoid structures. So our secondary lymphoid structures are structures that house our lymphocytes, our B cells and our T cells, and other immune cells such as our macrophages. And they are going to be found within reticular connective tissue. So remember that this is our connective tissue that has the reticular fibers within it. We typically have to use a special stain in order to be able to visualize those reticular fibers. And so we see within these tissues that we have these aggregates of lymphoid nodules that are going to be encapsulated with a dense, irregular connective tissue, so giving it a little bit more structure. And we see that capsule on the spleen and our lymph nodes. But we do have some other lymphoid structures that are going to have an incomplete capsule or not have one at all. And that would be in areas like our tonsils, MALT, which again is our mucosa-associated lymphoid tissue, and diffuse lymphoid nodules that we can find in certain organs of our body. So first, let's talk about those lymph nodes. Their job is to filter lymph. Remember we talked about that pathway? Let's just kind of draw it out to refresh our memories. We started with a blind lymphatic capillary, and we had a couple of those, right? So I'm going to kind of just draw some globules coming together, and then they formed a, or rather brought that lymph into an afferent lymphatic vessel. And then it's at that point that that vessel brought it into the lymph node. So here's my lymph node. It's not the best drawing here, and I should have left some openings here, but we are going to have several of these efferent lymphatic vessels then draining the node. So again, this is efferent lymphatic vessel. And then from the efferent lymphatic vessels, we'll have several of them filter into a lymphatic trunk. Okay, so lymphatic trunk. And from the lymphatic trunk, we are then going to drain into a lymphatic duct. And remember that we only have two lymphatic ducts. We have our right lymphatic duct and that thoracic duct. So anyway, we are focusing here on that lymph node. So let's clear this. Okay. So we'll see that these are these small oval encapsulated structures. They can vary in size, but be almost as big as an olive. And we find them in deep and superficial pathways of lymph vessels. They tend to be in clusters in areas, and the areas that they are most abundant is within the neck, called cervical lymph nodes, and those will drain the head and the neck. Or areas of the armpit known as the axillary lymph nodes, and this drains the lymph from the breast, the axilla, and the upper limb. And then we have our inguinal lymph nodes in the area of the groin that will drain the lower limbs and the pelvis. And here's a better visualization of what we were talking about with the afferent lymphatic vessels, how they are working to bring in all of that lymph into the lymph node. Notice how we have several of these afferent lymphatic vessels, but we're only going to have maybe 1 to 2 efferent lymphatic vessel that is allowing that lymph to move out of the lymph node. So we see that efferent lymphatic vessel at what we call the hilum of the lymph node, and the lymph node itself is surrounded by a very dense connective tissue capsule that encloses the node. Now, just like we saw earlier, we're going to see that capsule move in and create trabeculae and divide the area of the lymph node into these compartments. And in those compartments, we're going to have an outer cortex and an inner medulla. So the cortex will be the area where we will have the lymphoid nodules. And like I said, we have reticular fibers in there, and they help support an area known as the germinal center. The germinal center has all of the best stuff in it. So proliferating B cells and some of the macrophages. And then it has a surrounding mantle zone here that's going to contain the T cells, macrophages, and dendritic cells. Soon we're going to learn that dendritic cells are known to be antigen presenting cells, meaning that they are going to find a pathogen, take an antigen from it, and display it in order to alert our immune system. Our macrophages can also serve as those antigen presenting cells. And then surrounding that area we have the cortical sinus, and these are tiny open channels that are lined by macrophages as well. Now let's talk about the medulla. The medulla is going to contain medullary cord. So you could see that pictured over here, and we will see that we have connective tissue fibers that help to support our B and T cells and the macrophages. The medullary sinuses, which are just outside of that, are going to be tiny open channels that are lined with macrophages, similar to that of the cortical sinus here. So let's go back to the flow of lymph. So here we have our afferent lymphatic vessels, and the lymph is entering in. This creates pressure to push it through the node to a single exit. So because we only have one exit here, that causes this fluid to slow down and make more contact with the cells in here so that we can monitor it for foreign materials. Our macrophages in these areas will remove any foreign debris from the lymph, and our lymphocytes will initiate the immune response because hopefully those antigen presenting cells are going to show our B and T cells, hey, we've got a pathogen in here, we need to fight it. That will then cause our lymphocytes to proliferate. They are going to clone themselves, and this happens specifically in the germinal center. This can cause the glands to become, or sorry, not glands, but the lymph nodes to become enlarged. So when you go in to see your doctor when you're feeling sick, they typically will feel your neck region to palpate for enlarged lymph nodes. And then that lymph can exit through the efferent lymphatic vessel and pass to another lymph node to be filtered and surveillanced some more. Here's a clinical view on lymphoma. This is a malignant neoplasm from lymphoid structures. It is a non-tender enlarged lymph node, and it could cause side effects such as night sweats, fever, and weight loss. Now, if it's classified as Hodgkin's lymphoma, it typically will affect the young adults and people over 60 years old, and if it's caught early, it can be cured by excision, radiation, and chemotherapy. Now notice that the Hodgkin lymphoma is going to contain something known as the Reed-Sternberg cell, which you see pictured here with the non-Hodgkin lymphoma that doesn't consist of that. And what those cells are large abnormal white blood cells. And they tend to be the hallmark of Hodgkin lymphoma. If you have non-Hodgkin lymphoma, which is more common, then you will not see these types of cells, but your B and T cells can create a tumor. Some of these kinds are aggressive and others are more slow growing. Next, let's talk about the spleen. This is the largest lymphoid organ that we have, located in the left upper abdominal quadrant. I'm sure I've shown this to you in lab before. And we see that it's a bit lateral to that left kidney and posterolateral to the stomach. We see that that posterolateral side is convex and rounded. We do have the area where structures enter and exit that is known as the hilum, and it is more concave. So we call that the anteromedial surface or border. And we'll see the blood vessels entering and exiting here and some nerves. You all have seen that curly splenic artery that gives the spleen its blood supply, and then more of the straight collapsed splenic vein that drains the spleen. and will head back to eventually enter the hepatic portal vein. And the spleen itself is surrounded by a connective tissue capsule, and just like some of the other lymphoid organs, we see the capsule moves in to create trabeculae and divide out the spleen into areas that we call the red and white pulp. So the white pulp is going to be the areas where our B and T cells and macrophages are surrounded by a central artery. The red pulp surrounding this area, so we see it over here as well, is going to contain our red blood cells, hence we get that red color, and we also have platelets and macrophages and our B cells. Now within this area, we are going to see some splenic cords, where we have our cells and reticular connective tissue, and it surrounds a splenic sinusoid. This is going to be very permeable to capillaries, so we're able to shift the blood, and it's our red pulp itself is going to be a storage site for those red blood cells and platelets. So the reason we have our spleen is to really monitor the flow of blood, and we're going to be able to filter it, although it's not going to create any lymph like we saw within our lymph nodes. The white pulp is really looking for foreign materials and bacteria, which is a foreign material itself, and then in the red pulp we will have macrophages, specifically within those sinusoids that we saw, that will help to remove particles. It can also phagocytize bacteria and get rid of any defective erythrocytes or red blood cells and platelets. So this is the way that blood flows into the spleen. We are first going to move out the splenic artery, which if you remember is coming from our celiac trunk, and then we'll split into a central artery. So we see that central artery over here, and from there it is going to move into the sinusoids that we saw, and from the sinusoids it moves into venules and then out a splenic vein. So here's a little summary of the functions that we have. It's going to eat any foreign particles or pathogens like bacteria. It clears any defective red blood cells or platelets, and it can also store our red blood cells and platelets. And just a fun fact is that in the first 5 months of our fetal life, our spleen is the one that makes our blood cells, and then that function kind of stops, and sometimes this function can be reactivated under certain conditions. For example, if we had a hematologic disorder, such as extramedullary hematopoiesis, our spleen could be called to action. And here's a clinical view on splenectomies. So this is when we surgically remove the spleen, and it could be due to a ruptured spleen from some type of abdominal injury, which is the most common reason for this. It could be due to some type of infection, a cyst or tumor, or lymphoma or another type of cancer. Sometimes blood disorders such as sickle cell anemia may also cause us to remove the spleen as well if it is hyperactive and we are having to destroy all of these abnormal red blood cells, and it may be more prone to life-threatening infections. Now let's talk about the tonsils. We're going to find these in the area of the oral cavity and the nasopharynx. First off is the pharyngeal tonsil in the roof of the nasopharynx, and when they become enlarged we call these adenoids. We have seen an increased amount of a need to remove these adenoids in children because they've just become so enlarged that it is impacting the child's ability to breathe, especially when sleeping. Another tonsil that can be removed is the palatine tonsil, and we find this in the posterolateral oral cavity. So if you were to have somebody go ah and open up their mouth, you're going to see that uvula in the center, that ball hanging in the back of their throat, and then look along the lateral walls and you'll find the palatine tonsils on either side. And lastly, we have the lingual tonsil, which is found at the base of the tongue here, in the posterior 1/3 of that tongue. Now, taking a look at the tissues here, we classify it as a secondary lymphoid structure, and it too is going to work as a type of immune surveillance of inhaled and ingested substances. So if we look at the tissue, we see these deep invaginations that we call tonsillar crypts, and they are there in order to trap materials, and we can hopefully come into contact with the immune cells that we find within the lymphoid nodules here. And some of these, if you look closely, are going to contain that germinal center. A clinical view here of tonsillitis and tonsillectomies. So if we have acute tonsillitis, this is inflammation and infection of the tonsils. So here pictured are the palatine tonsils, which are most commonly affected. You could see that they are reddened and enlarged, and they are starting to obstruct the pharynx here. You may also have some symptoms of fever, chills, sore throat, and difficulty swallowing, and it could either be due to a bacterial infection or viral infection. Some patients will see recurrent infections, which we call chronic tonsillitis, and in that case we are going to say that you need a tonsillectomy, and that means we are surgically going to remove the tonsils. So you can see that this tonsil is being held through some forceps and being pulled out. And lastly, let's talk about the lymphoid nodules and MALT. We are going to find these all throughout the body. They are just clusters of lymphoid cells with some of the extracellular matrix. We're not always going to have that capsule present, but we may have some scattered nodules throughout the connective tissue. And we call this diffuse lymphoid tissue. And we have it all over the body because we are going to try to defend infection and have these immune cells present throughout. So in some areas, we'll see that there are larger structures all put together. So for example, we have MALT, which stands for our mucosa-associated lymphoid tissue. We're going to find this within our GI tract, the respiratory tract, genital tract, and our urinary tracts. So we do have some different names for these, but in general, we could just call it MALT. And we find it in the area of the lamina propria of the mucosa. Like we said, these nodules are here so we can defend our body against foreign substances, and we see a prominence, especially within the ileum here, what we are going to call our Peyer's patches. These are the lymphoid nodules. You could see that they are all kind of sat in a row next to one another to defend our body.